Breastosis is defined clinically as the progressive inferior migration of the nipple areola complex, or NAC, relative to the inframammary fold. In the Ragnow classification system, grade 1 ptosis occurs when the nipple descends to sit at the exact level of this fold. As the condition progresses through grades 2 and 3, the nipple drops completely below the lower contour of the breast, accompanied by an accumulation of redundant tissue in the lower skin envelope. This is distinct from pseudotosis, a condition where the upper quadrant loses glandular volume and deflates, but the nipple itself remains at or above the inframammary fold. This morphological shift creates physical discomfort and carries significant emotional weight for the patient. To understand why this happens, we have to examine how the breast transitions from a dormant adipose organ into a high-functioning secretory apparatus, a shift that demands rapid structural adaptation. There is a pervasive misconception among both patients and clinicians that the mechanical act of breastfeeding, the physical suckling and downward pull, is what stretches the breast tissue. Current medical literature confirms this is incorrect. The mechanics of infant feeding are etiologically insignificant to the development of ptosis. The dominant predictors of ptosis severity are the total number of pregnancies a woman experiences, her pre-pregnancy body mass index, and lifestyle factors like smoking. The actual underlying cause is a highly specific, endocrinologically mediated degradation of the breast's internal scaffolding. This chemical deterioration is compounded by the extreme static and dynamic volumetric loading that takes place immediately postpartum. Breastosis is a failure of the internal scaffolding, a process initiated by pregnancy hormones and accelerated by individual mechanical and lifestyle stressors. Unlike other regions of the body, the female breast lacks intrinsic muscular support. Its structural integrity relies entirely on connective tissue. This framework is the breast fibrostructural support system, composed primarily of fibrous, semi-elastic fascial layers, known as Cooper's ligaments. Histologically, these ligaments are constructed mostly of dense, high-tensile type 1 collagen, designed to hold tissue in place against gravity. This graph displays the behavior of healthy Cooper's ligaments under physical load. Uniaxial tensile testing shows a steep curve of resistance as tension increases. Stiffness becomes highly consistent only after the collagen fibers are fully stretched, reaching maximum tension resistance. Because this connective system must tolerate the entire dynamic load of the breast mass, any chemical alteration to its tensile strength risks an architectural collapse. During the first trimester, a massive systemic influx of hormones floods the body to orchestrate glandular development and modify connective tissue. The primary architect of tissue laxity is the H2 relaxin peptide, encoded by the RLN2 gene, which reaches its peak concentration at 12 to 14 weeks of gestation. Relaxin molecules flood the extracellular matrix, actively binding to G-protein-coupled receptors, known as RXFP1, within the connective tissues. This binding initiates a downstream signaling cascade that rapidly upregulates Matrix Metalloproteinases, specifically MMP1 and MMP3. These enzymes actively digest and degrade the load-bearing type 1 collagen of Cooper's ligaments, physically severing the high-tensile fibers. Biologically, this degradation serves a precise purpose. It increases collagen turnover to intentionally soften the internal scaffolding, allowing the impending expansion of glandular tissue. By dismantling its own high-tensile structural support system, the maternal body drastically lowers the failure threshold of the breast's internal architecture. Relaxin doesn't work alone. Estrogen acts as a secondary destructive force on the connective tissue matrix. Estrogen actively inhibits lysyl oxidase, an enzyme essential for the cross-linking of new collagen fibers, preventing the matrix from repairing its lost tension. Simultaneously, estrogen stimulates the arborization of the ductal system and doubles the localized vascular blood supply. Progesterone works concurrently to stimulate the proliferation of the milk-secreting acinar glands, while also causing soft tissue fluid retention. The structural scaffolding is severely weakened by enzymes and blocked from repairing itself, right at the exact moment the organ begins to rapidly accumulate dense fluid and tissue mass. The breast is now structurally primed for failure, possessing a compromised matrix that must eminently support a massive, unprecedented physical payload. The sudden mechanical trigger occurs immediately following birth. The expulsion of the placenta drops progesterone levels tenfold, instantly removing the inhibitory block on prolactin. This initiates stage 2 lactogenesis, the onset of copious milk secretion within 36 to 72 hours postpartum. This area chart demonstrates the resulting catastrophic volumetric load. Milk production explodes exponentially, rising from a baseline of 50 milliliters to over 500 milliliters per day in that short window. This rapid fluid accumulation causes severe physical engorgement, stretching the skin envelope to its absolute maximum capacity. These immense static and dynamic loads are now pulling directly on the chemically digested, uncross-linked Cooper's ligaments. Unable to support the rapid weight gain, the ligaments are pushed entirely beyond their natural elastic yield points. This rapid volumetric expansion acts as the definitive breaking point, irreparably tearing the softened architectural scaffolding of the breast. The final stage of this process is post-lactational involution, the phase following weaning where prolactin levels decline and milk production ceases. The cellular response during involution is driven by apoptosis, the rapid, programmed cell death of the milk-secreting epithelial cells. This creates a gross anatomical disparity. The heavy glandular volume disappears rapidly, but the overstretched skin and Cooper's ligaments cannot bounce back. This graph illustrates the engineering reality. The ligaments have suffered plastic deformation. They have been stretched past their elastic limit and permanently lengthened. Clinically, the breast tissue now sags freely within the redundant envelope. Post-lactational involution does not cause ptosis. It merely removes the fluid volume that was temporarily masking the catastrophic ligamentous destruction underneath. This connective tissue remodeling is not localized solely to the breast or pelvic region. The destructive antifibrotic effects of relaxin and estrogen induce systemic ligamentous laxity throughout the entire musculoskeletal system, increasing the risk of peripheral joint injuries like ACL tears. This technical chart illustrates empirical data on muscle tendon morphology. Looking closely at sections B and C, we see a quantitative shift in fiber diameter and the transition of muscle fiber types across non-pregnant, pregnant, and lactating states. These systemic muscle tendon shifts mirror the local destruction in the chest, confirming that the maternal body globally sacrifices its connective tissue integrity. Gestational breast ptosis is just one highly visible symptom of a global structural remodeling required to accommodate human reproduction. Because the collagen matrix has been degraded at the molecular level, non-surgical or conservative recovery of breast ptosis is biologically impossible. Mechanical re-engineering through surgical correction, specifically a mastopexy, remains the only viable method to restore the failed architecture. A mastopexy procedure re-engineers the breast by manually excising the redundant, overstretched skin and mechanically repositioning the nipple areola complex higher on the chest wall. When this skin lift is combined with an implant, an augmentation mastopexy, the procedure also artificially replaces the volume loss to post-lactational apoptosis. Ultimately, the clinical and scientific consensus is clear. We must stop blaming the physical mechanics of breastfeeding for a structural failure engineered by gestational endocrinology. Breast ptosis represents a permanent physiological sacrifice of the mother's fibrostructural scaffolding, a complex engineering failure designed specifically to ensure infant survival.